Just be happy with who you are. Just be happy with who you are. Just be happy with who you are.
Hi, and now we're going to start with part 2, where we're going to look at the Diagnostic and Statistical Manual of Mental Disorders, the DSM. It's the most widely accepted diagnostic system, now in its 5th edition. Another widely used system is the International Classification of Diseases, the ICD. It's published by the World Health Organization. Now it's in its 10th edition with the Canadian enhancements and modifications. The system is now known as the ICD-10-CA, which has been adopted by the Canadian Standards of Coding, Reporting, and Tracking of Health Information. We're going to focus on the DSM-5 for our purposes, as it will help us understand how clinicians categorize psychological disorders. We're going to start with reviewing the DSM-5 as a diagnostic tool and in terms of what and how does it aid clinicians. We will follow this with methods of treatment, and including the biological, psychodynamic, behavioral, humanistic, cognitive behavior, eclectic, and group, family, and marital therapy, indigenous healing, and computer-assisted therapies. And these are classifications of treatment that would generally be happening for people with psychological disorders. Classifying disorders, not people, classification is the core of the scientific enterprise. You can label jars, not people, is used by People First. It's another separate group that doesn't relate to psychological disorders, but it reminds us that we don't label people, we label we classify disorders, but we don't label people. By saying that that's the schizophrenic is to label the person by the disorder. To say that that person lives with schizophrenia is to not label the person, but label the disorder. Labels make communication about psychological disorders possible. An attempt to define and discover actual diseases, mental or psychological disorders, we just need to ensure that we remember that people come first. Even in our language, instead of saying schizophrenic, we should address the person who lives with schizophrenia, being careful not to have the label, but be careful not to label people. The DSM uses specific diagnostic criteria to group patterns of abnormal behavior that share common clinical features. Strengths of the DSM include that it uses specific diagnostic criteria to provide a picture of what that person's disorder or weaknesses might be. The weaknesses in terms of the DSM-5 is that includes questions about reliability and validity and about the medical model framework. And so these tools aren't perfect, and it hasn't been perfect since its onset, but it's the best thing that we have currently. Now, additionally, there has been criticism regarding its use as a categorical approach to the diagnosis of disorders, which have been addressed in the DSM-5, released in 2013. For clarification, the terms validity and reliability, we'll clarify that because I mentioned in the first part that we would revisit it, and we're going to do that here. Validity is the extent in which a study or research instrument accurately measures what it's supposed to measure. So if you were weighing yourself as an example, if you were using a weigh scale and you jumped on it, sometimes it measured your weight and other times it measured something else. Well, it's not very valid. It's to say that weigh scales measure weight. They don't measure intelligence, creativity, or communication skills. That weigh scales measure only weight makes them valid. It's measuring what it's supposed to measure. Reliability, on the other hand, is the extent to which a study or research instrument yields consistent results. So again, you're jumping on the weigh scale, and at 8 in the morning you weigh whatever you weigh, and you jump on it half hour later without having eaten anything, and you find that it's 100 pounds heavier. It's not consistent in what it measures. It measures weight, but it doesn't measure it accurately every time. And so reliability is about consistency, that it does what it's supposed to do every time, and validity is that it measures what it's supposed to measure. Now, the DSM-5 classifies abnormal behavior patterns or mental disorders according to developmental models. This allows relevant lifespan information to be included in decisions regarding clinical diagnosis. Moreover, the DSM-5 deliberately employs dimensions rather than categories in evaluating abnormal behavior. When a diagnosis of mental disorder is made, other pertinent details are gathered from the individual, such as the psychological and environmental conditions which influence the persistence of the disorder. The impacts of the disorder has on the area of the individual's life also is documented. At what point does it have the most impact? For example, a diagnosis of depression may have significant influence on a student's ability to fulfill his or her typical role functions. The DSM-5 has undergone structural changes such as the elimination of 5 levels of multi-axis systems, that's in DSM-4 and earlier, the design of the previous editions, a major reorganization and regrouping of disorders also occurred. New disorders have been added, including disruptive mood dysregulation disorder, the DMDD, the premenstrual dysphoric disorder, PMDD, and hoarding disorder have been added. Asperger's syndrome was eliminated in favor of the broader category named autism spectrum disorder. And so there's been a controversy with the DSM-5, as there has been controversy in previous editions as well. So what we're going to focus in on is treatments. And here we're going to look at a wide variety of treatment options. But who provides treatment? The majority of licensed mental health professionals in Canada are clinical psychologists, psychiatrists, and social workers. In the cluster formed of psychotherapists and counselors, there remains a lack of common pan-Canadian titles and clearly defined scopes of practice, with regulations varying among provinces. And so it's been not delivered by the same sorts of groups of people with the same level of expertise. So in this area, we're going to just do a quick review of treatments as well as a review treatment options as part of each category of disorders. As always, additional information is found in your textbook. So I'm going to start with the biological approaches and include drug therapy, electroconvulsive shock therapy, and psychosurgery. Now, minor tranquilizers such as Valium may relieve short-term anxiety, but they do not directly help people to solve their problems. Neuroleptics help relieve flagrant psychotic features, but regular use of most antipsychotic drugs has been associated with the risk of disabling side effects. Antidepressants have been shown to be effective in treating depressive disorders, and lithium has been shown to be effective in treating bipolar. There isn't like a reliable, this medication will do this for this person. A lot of it is based on fine therapeutic levels. So whatever medication somebody has been given, being able to track on a regular basis blood tests to see at what level of effectiveness is the medication in the bloodstream to know whether we're in a therapeutic range or too high or too low. Now, ECT, or electroconvulsive therapy, is often associated with a dramatic relief from severe depression, but questions still remain about the side effects. And this is where you are actually giving someone shocks to the brain. It has actually found to be fairly successful with some forms of depression on the extreme side, but it's not something that's commonly used. Psychosurgery is conducted only rarely because of adverse consequences. And psychosurgery really just means surgery on the brain for reasons to cure or correct abnormal behavior. Now, deep brain stimulation involves implanting electrodes within part of the brain that affect mood. There is some positive effect from mood elevation for severe obsessive compulsive disorder and Parkinson's. However, it is limited, and it's not approved for other disorders like depression. Psychodynamic therapies originated with psychoanalysis, the approach to treatment developed by Freud. Now, psychoanalysis uses techniques such as free association and dream analysis to help people gain insight into their unconscious conflicts and work items through in the light. Just other therapies can last many months or even years, and more recent psychoanalytic therapists are generally briefer and less intense. So free association, is to sit, lay back, and continue to talk about whatever is on your mind. Let your mind wander. The therapist sits out of sight, and that's why you often saw pictures of Freud where his patient was on a couch and he was out of, behind them where they couldn't see him. So you're out of mind and out of sight, and after many sessions, the therapist offers an analysis of patterns and disclosures, drawing your attention to potential connections. And so this free association brings to light some things to the observer. Now, there was some risks, and one of them was called transference. And through therapy, a client may or may not only interact with the therapist as a therapist, but at time also as another important person in their life. And this can be helpful, as in role-playing, or it can be problematic in the client's relationship when they expect the same level of caring and feedback from the therapist. Now, the more recent psychoanalytic therapies are generally briefer and less extensive. These newer psychodynamic therapies will look at the unconscious, but are more focused on the present, and they sit face to face and play a more active and engaging role. Behavior therapy applies principles of learning to help people make adaptive behavioral changes. Behavior therapy techniques include systematic desensitization for phobias, gradual exposure, modeling, aversive conditioning, operant conditioning approaches, social skills training, and self-control techniques. Humanistic approaches, they focus on clients' subjective conscious experience in the here and now. See, that's unlike some of the psychoanalytic where they look back into the person's past and see how those past and unconscious things can influence in today's world. The humanistic approach is the here and now. Carl Rogers' person-centered approach to therapy helps people increase their awareness and acceptance of the inner feelings that of the inner feelings that had been met with social condemnation and even been disowned. The effective person-centered therapist possesses the qualities of unconditional positive regard, empathetic understanding, genuineness, and congruence. And so that became really important to the therapist, that they needed to present themselves in a very positive, unconditional regard for the other person and create that relationship and that dialogue. Cognitive therapies, they focus on modifying the maladaptive cognitions or thinking patterns that are believed to be underlying emotional problems and self-defeating behavior. Ellis's relational emotive therapy focuses on disputing these irrational beliefs that affect emotional distress and substituting adaptive behavior for maladaptive behavior. Aaron Beck's cognitive therapy focus on helping clients identify challenges and replace distorted cognitions, such as the tendency to magnify negative events and minimize personal accomplishments. Donald Mickelbaum, from out of the University of Waterloo, developed a cognitive behavior therapy, which attempts to integrate behavioral principles and cognitive techniques in a way that reduces or eliminates problematic behavior and changes dysfunctional thoughts and cognitions. Now, there is another group, it's called eclectic therapists, which make use of multiple models of psychotherapy. So eclectic meaning a variety of different things and unusual things, if you will. In technical eclecticism, therapists use techniques from different approaches without necessarily adopting the theoretical models on which they were based. So in an integrative eclecticism, try saying that a little bit, therapists attempt to synthesize and integrate diverse theoretical models. So that's one of the biggest things about eclecticism, is that it's looking at drawing from different things and bringing them into one without being necessarily expert in all, and the foundation which they were developed from isn't as necessary as just the application. Now, some of these next sort of therapies you will have heard of before, but they are also important in the support of people with psychological disorders. And one of those is group therapy. And it has several advantages over individual treatment, such as reduced costs, opportunities for shared learning experiences and mutual support, and increased utilization of scarce therapist resources. The particular approach to group therapy depends on the orientation of the therapists. Now, in addition to group therapy, there is family therapists, which work with conflicted families to help them resolve their differences. Family therapists focus on clarifying family communications, resolving role conflicts, guarding against scapegoating individual members, and helping members develop greater autonomy. Marital therapists focus on helping couples improve their communication and resolve their differences. Indigenous people view mental wellness as a form of balance of physical, mental, emotional, and spiritual aspects, and is on a continuum from minimal to optimal. All people are seen as interconnected. Attaining optimal levels of wellness requires the strength of not only the individual, but also the family and the community. In the indigenous healing perspective, healing and wellness promotion are multi-leveled, targeting the individual as well as the family and the community, while rejecting both individual and group languages, customs, history, and environment. In a relatively new way of delivering, it's not entirely new, but it sounds newer. I was using this technique or this strategy back many years ago in the 90s when I had my own business doing counseling, and that's computer-based interventions and therapy, and they come in all forms. They can be online cognitive behavior therapy with a live therapist, using a video chat service to self-guide behavior therapy for children with anxiety. It can be computer-based interventions from various disorders that have potential to dramatically expand and after the landscape of treatment. So what's really interesting about these different treatments is that it's the therapist's role to figure out which is going to be the best approach to use for each individual person and whatever psychological disorder. So lastly, we're going to touch on what the psychiatric commitment and patient rights are. The legal process by which people are placed in psychiatric institutions against their will is called a psychiatric or civil commitment. And that can happen, it's just not common. Psychiatric commitment is intended to provide treatment to people who are deemed to suffer from mental disorders and pose a threat to themselves or others. Legal or criminal commitment, by comparison, involves the placement of a person in a psychiatric institution for treatment who has been acquitted of a crime by reason of insanity. The person is entitled to due process. There needs to be deemed an imminent risk to self and others, and limited time, 72 hours, pending more information. In voluntary hospitalization, people voluntarily seek treatment in a psychiatric facility and can leave of their own accord unless the court rules otherwise. So who's the most dangerous? Look at the images there. How do we predict who's the most dangerous? Is it apparently drunk driver? A. Is it the institutionalized psychiatric patient, B? Or is it the scheming corporate executive, Bernie Madoff, C? There's no absolute right answer. And although information disclosed, so when we think in terms of dangerous, it's really not easy for everyone to determine. So getting somebody hospitalized because they're a danger to self is not something that happens very commonly. Now, although information disclosed by a client to a therapist generally carries the right to confidentiality, the California Tarasoff ruling held that therapists have a duty and or obligation to warn third parties of threats made against them by their clients. This doesn't apply in Canada yet. Now, patient rights include the right to treatment that is least restrictive. That means techniques, the techniques are least restrictive to restrictive. It means you get community support over institution if it's available and or possible. You have a right to refuse treatment. Even if someone would have benefited from the treatment, if they are not of imminent risk, they can refuse treatment. Most people in need do not refuse treatment. This completes an overview and introduction to abnormal psychology. Now we're going to begin in week 3 to explore different types of psychological disorders and the theoretical perspectives to explain them and the treatment options currently available. And we're going to start this in week 3 with anxiety, obsessive compulsive, and trauma and stress related disorders. Now I'll be making, in those weeks that I'm doing psychological disorders, I'll do 3 videos per week. 1 will be the description, 2 will be causes, and 3 will be treatment, just to keep things organized. All right? So I hope everything's going well, and we'll see you next week. So good luck and keep up the hard work.